One of the other elements that is currently at play here is that several states have enacted legislation that actually mandates the use of ADF opioids over their non-ADF counterparts. And in a situation like this, where the ADF opioids cost much more money, we need to understand whether there is evidence to support that. There's some confusion about what ADFs are and what they are not. So abuse-deterrent formulations, as I mentioned, have deterrence to abuse and manipulation, but they still contain the same opioid as non-ADF formulations, so they are just as addictive. What would really be helpful, and in fact the FDA has asked for this in the past, is a study designed prospectively. So from the point of a first prescription for whatever the therapeutic reason is, a group of patients getting ADFs and a group of patients not getting non-ADF forms, to try to understand then over time what the rates of abuse, misuse, and diversion look like. No such study has been done to date. The studies that focus on diversion, for example, of OxyContin, look at the diversion of that product alone without understanding whether individuals who might be frustrated by the ADF properties of OxyContin might be switching to something else, another opioid that's easier to abuse, or maybe even an illicit opioid like fentanyl or heroin. We certainly heard from participants in our meeting and other stakeholders, again, that there is likely a population that's at high risk of abuse that would benefit from ADFs, and we don't know yet exactly how to identify those individuals, but if further research is done and we can identify them, then they would be appropriate candidates. We definitely heard from stakeholders that even if a high-risk subset of patients could be identified, there were still challenges and barriers to getting those patients access. And these are both on the manufacturer side as well as on the insurer side. Manufacturers can certainly kind of moderate the right they have to price according to their monopoly pricing power by reducing those prices to be in line with the benefits that we see in terms of reduced abuse and diversion. So what we found was that if the ADF opioid prices were reduced by about 40%, then the health system would break even. Now, interestingly, that reduction still provides about a 20% premium for the ADFs because they're saving money with reduced abuse. So there's still the allowance of a premium price, but it should not be the premium that currently exists. That's essentially the conclusions of our model. But we also heard that insurers have barriers in place now to ADF use that could be removed for the appropriate patient. So, for example, as the prices of any drug go up, payers typically ask individuals to pay more out of pocket. And again, if an appropriate individual who would benefit from an ADF and be at lower risk of abuse is identified, it would make sense to reduce that burden on them so that there's no disincentive for them to move to a non-ADF opioid, which might be more risky for them.